right, so we're actually going to start our last breakout session of the day. If you are here, you are going to hear Gina and I talk about top 5 clinical ethics. Now, Gina, you have said that you were going to talk fast, right? Mm-hmm. Because there's a lot to cover under the topics that we've chosen. So without further ado, Gina.
All right. This is going to be like speed round. So, of course, I can't see my slides. We don't have a remote clicker, do we?
We do.
Oh, then I'll use that. And then I will... we don't have a remote mic, do we?
No, but we can take this off. We do have a remote.
Okay, that'll perfect.
Yep. And then you can...
And then I can meander around. Okay. So Grace wanted me to do the least controversial topic, so I'm going to talk about abortion, in vitro fertilization, and women's health. Nothing controversial there, right? I cope with stress by humor. And so I start with this. How dare you question our medical expertise? We went to the top law schools. Right. This one may be a little bit more controversial. If you wanted rights, you should have been a corporation or an embryo. There we go. Okay. So, obviously, a lot of these topics really come down to what do you think of as the moral status of embryo or fetus? Do you, as some would say, think of the fetus as a person with the same right to life as any human who has been born? Or do you think that the pregnant woman has some say in this? Does she have an obligation to gestate the fetus? And how you answer those questions really kind of depends on where you come down on this question. The Catholic Church typically has said that the embryo is thought of as a full human being from conception, and that abortion is not okay, even when there's a threat to the life of the woman, because you can't sacrifice one life to save another. And that's kind of at the one end of the spectrum, right? So as those of you know, 1973, the Supreme Court affirmed a right to abortion. And it's really interesting, right? Because it's under the Due Process Clause of the 14th Amendment, which really talks about this fundamental right to privacy. So it really wasn't about abortion. It was about privacy. But they said it's not absolute. The government does have an interest in protecting women's health and prenatal life. Casey was a case that was brought in 1992, and this was also a threat to Roe. But it affirmed Roe, and it said it allowed states to restrict abortions based on a concern for women's health so long as the restrictions did not impose an undue burden. So in Texas in 2013, they tried to get a law passed that said if you are an abortion provider, you must have hospital privileges at a hospital within 30 minutes of where your clinic is, and that the abortion clinic had to be equipped just like an outpatient surgery center. So there were these limits that they wanted to impose that made it very, very difficult. Now, of course, June of 2022, the Supreme Court came out and overturned Roe, and they really said that, as far as I can understand, mainly because abortion is not mentioned in the Constitution, therefore, you really don't have a right to it, right? They said a substantive right to abortion was not deeply rooted in this nation's history or tradition. There's actually a lot of things that are not mentioned in the Constitution that people are worried about that they might lose. Certainly, same-sex marriage, even interracial marriages, other things that they may question here. So that's an interesting thing to note. So here it shows you a map of where the reddish-orangish ones are where abortion is banned. Yellow is legal with gestational limits, and the blue is still legal. So we're going to talk about that little funny-shaped place right up on the right-hand corner, Idaho, right? So abortion laws and EMTALA. So how many people know what EMTALA is? If you're a clinician, you know what EMTALA is. So EMTALA is this emergency medical treatment an active labor act. Basically, it says if someone shows up in your emergency department and they're in active labor or have some other medical emergency, you must treat them. Doesn't matter if they have insurance, doesn't matter if they can pay. It was really a way to make sure that people could get treated, which is very interesting because the emergency department is probably the least efficient, least effective place to get treatment, but everyone can get it, right? That's kind of the way our healthcare system has been set up. So there's a couple lawsuits, Idaho versus the U.S. and Mohr versus the U.S., which the federal government is saying, listen, your ban on abortion violates EMTALA, right? And how do they say it does that? The Defense of Life Act in Idaho says that it outlaws all abortions except in cases of rape, incest, which must have been reported to police. We know that there are many cases of rape and incest that occur that for many, many reasons do not get reported because that's kind of another trauma. Or to save the life of the pregnant person. The life, not necessarily her health, but her life. Anyone who performs an abortion not covered by the exceptions faces up to 5 years in prison. So part of the question then is, so what circumstances really count? The federal government says that medical care that a state may characterize as an abortion is necessary emergency stabilizing care that hospitals are required to provide under EMTALA. So things like ectopic pregnancies, severe preeclampsia, or other things that might put you at risk of having a bad infection or bleed. The federal government is saying, listen, your law makes it so that doctors can't do these things. The states come back, and Idaho comes back and says, no, we have these exceptions. But the problem is, how close to death does a woman have to be in order for a doctor to act? And, I don't think I realized this. I didn't think about it as much until Roe got overturned in a lot of the cases that we see as ethics consultants. Cases such as preterm, pre-viable rupture of membranes. Right, so let's say a woman comes in at 16 weeks, she's had a gush of fluid, she has no more fluid anymore. Now that she's had that rupture of membranes, she's at risk for getting infection, getting septic. But she's pretty stable, she's fine, she doesn't have a fever right now. The baby won't survive because now there's no fluid, can't develop lungs. So we know this is not going to be viable. And yet, is she sick enough? And in Idaho, we have to think about this. In California, fortunately, we don't. But in Idaho, there are many physicians who have left, OBGYNs, maternal fetal medicine folks, who say, I can't practice under these circumstances, right? Because will doctors be willing to risk jail time? And so the Idaho state is trying to say, don't worry, you're covered. But others who may not be as trusting kind of scratch their heads and say, will I be covered? Will I be questioned about my medical judgment after this has taken place? So that's part of the concern. Interestingly enough, there are no rape or incest exceptions in the following states: Alabama, Arkansas, Florida, Kentucky, Louisiana, Missouri, Oklahoma, Ohio, South Dakota, Tennessee, or Texas. So Dobbs, the Supreme Court.
Yeah, Florida just this week signed a new law that shortened it from 15 weeks to 6, but added rape and incest.
Thank you for that. So yes, Florida just changed this week. Florida was kind of like this, I guess depending on your viewpoint, right? This little oasis in a bunch of states that didn't have abortion, or maybe this other viewed place. But Florida just changed so that no abortions can take place after 6 weeks, but they do have an exception. Most states have exceptions for the life of the mother. But again, how sick does she have to be? That is very unclear in most of the states. So the Supreme Court expressly noted that its opinion is not based on any view about if and when prenatal life is entitled to any of the rights enjoyed after birth. So the Supreme Court stopped there. So guess who stepped in to say what that was? Well, it's Alabama, right? In February of this year, the Alabama Supreme Court said that the Wrongful Death of a Minor Act applies to all unborn children regardless of their location, and that can be extrauterine, okay? So So embryos, typically in vitro fertilization, there may be multiple embryos that are on cold storage, right, and are either being waited upon to use, or maybe if they get a successful pregnancy, then they may not need the rest of the embryos. And so typically in IVF, often embryos are discarded. When this law was passed, and it came about, there were 3 couples that sued an IVF clinic after a patient with what sounds like a psychiatric disorder, he gained access to the clinic, went and was messing around with some embryos, dropped them, and they were destroyed. So they sued this clinic, and the couple argued that the clinic was civilly liable under Alabama's Wrongful Death of a Minor Act, which allows for compensatory and punitive damages. It was a dismissed wrongful death claim as it did not include in vitro embryos. So the trial court under the Supreme Court said, no, you don't have a case. It doesn't include in vitro embryos. But you could get some damages because of breach of contract. The court found that the plain meaning of minor in the act, which was originally in 1872, so a little bit before IVF was even invented, right? There was no such thing. There was no such technology. Based on that act, the Supreme Court said included all children, born and unborn, regardless of their location in utero or not. The dissent, there was one dissenting judge in this case. He argued that the Alabama law, legislative intent, and previous court precedent all made clear that an unborn child does not include embryos. So he was kind of the lone voice. And this is what he said, Justice Cook: to equate an embryo stored in a specialized freezer with a fetus inside of a mother is engaging in an exercise of results-oriented intellectual sophistry. The other thing that the clinic said, the clinic claimed the couples had actually treated the embryos as non-human property because in the contract that they made up, they had various disposition choices, which included variable choices of the couples to destroy embryos after 5 years, to donate excess or abnormal embryos for medical research. So in the contract, they had basically treated it like property. And so if they're going to say that, then it's fundamentally incompatible with wrongful death claims. Justice Parker, this is the Supreme Court justice, and this is what he said. The theologically based view of the sanctity of life adopted by the people of Alabama encompasses the following. God made every person in his image. Each person, therefore, has a value that far exceeds the ability of human beings to calculate. Human life cannot be wrongfully destroyed without incurring the wrath of a holy God who views the destruction of his image as an affront to himself. Section 36:6 recognizes that this is true of unborn life, human life, no less than it is of all other human life, that even before birth, all human beings bear the image of God, and their lives cannot be destroyed without effacing his glory. Now, as Christians, we may actually agree with a lot of that. But the question is, do you want that coming from the Supreme Court and into law? So that's part of the concern. Justice Cook came back and said he recognized that this would be very problematic to people who perform IVF, and said no rational medical provider would continue to provide services for creating and maintaining frozen embryos, knowing that they must continue to maintain such frozen embryos forever, or risk the penalty of a wrongful death act claim for punitive damages. And that's in fact what happened. As soon as this law was passed, many institutions stopped doing IVF because they were really worried that they would be held accountable because embryos were children. So quickly, the Alabama legislature said, oh, maybe people aren't happy with this, so let's pass a new law that grants civil and criminal immunity to people, to IVF clinics. No action, suit, or criminal prosecution for the damage to or death of an embryo shall be brought or maintained against any individual or entity when providing or receiving services related to in vitro fertilization. Now, it does not address whether embryos created through IVF are considered children. That is for another day and maybe another ABC conference. So I'll leave you with this. Relax. I hid the contraceptive pills in the gun because that's where they'll be safe. Okay, Grace, it's all yours.
Oh boy, that was a rapid tour through abortion, IVF law. Thank you. All right, so if we could bring up my presentation, I am going through three additional topics that have been pretty hot in the clinical ethics world. So I'll be going through changes to brain death. I will be going through transgender care or changes to patients or caring for transgender patients. And the last, I'm going to be going through something called NRP-DCD, which is a whole mouthful, and it stands for normothermic NRP reperfusion, normothermic regional perfusion in controlled donation after cardiac death. Whew, that was a mouthful. Okay. Let me use this here. And then we will have time at the end for questions. So death by neurologic criteria or brain death. I think it's helpful just to look at a brief history of how we got here. So I start here in 1968, but please note that in the early or the mid 1900s was a time of great technological advancement. And one of the greatest technological advancements was actually the development of the ventilator. So it allowed hospitals to keep patients alive by artificially performing the actions of the lungs, and allowed patients with severe neurologic brain injury to actually survive instead of die as they would previously. And so because patients with severe neurologic injury were living, it was felt that we needed to have another definition of how to declare death. So prior to this, the only way to declare death was by cessation of the heart, of our cardiac activity. But in 1968, we had a publication, a seminal publication in JAMA called the Ad Hoc Committee of Harvard Medical School to examine the definition of brain death, and it described and codified the concept of brain death. Over the next 20 years, we started to have a growing movement to enshrine brain death into legislation. And so in 1981, we had the introduction of the Uniform Determination of Death Act, which was a model state law that has been adopted by all 50 states, territories, and also the Washington, D.C., that defines brain death as the cessation, and this is really important, it'll come back, the cessation of cardiopulmonary activity or the irreversible cessation of function of the entire brain. And that means that the cortex as well as the brainstem must not have function. Now, this is a distinct difference from what is done in the UK, which the UK accepts the brainstem standard, which means that you but in order to declare brain death, you do not have function of the brainstem. Well, after the adoption of Declaration of Brain Death, then there came the questions of how do we do this? And so the American Academy of Neurology came in and they published guidelines They published guidelines for how to declare pediatric brain death in 1987, adult brain death in 1995. But even with these guidelines, there was a bit of evidence, very disturbing evidence, to show that those who were pronouncing brain death weren't actually following the guidelines. Now, this got a lot of people quite excited, and so there was another push to redefine these guidelines. And so in 2010, the American Academy of Neurology published revised adult guidelines. 2011, Society of Critical Care Medicine published revised pediatric guidelines. However, even though we have these guidelines, now remember that UK has a different brain death standard. Well, it turns out that brain death is viewed differently throughout other parts of the world. So while in the US there may be a uniform adoption of the concept of brain death, there wasn't the uniform adoption worldwide. And so the World Brain Death Project came out of really this guideline revision from 2010 and 2011, which included worldwide societies, medical societies, and professional bodies. And they set out minimum criteria for brain death that was endorsed by 5 world federations, 27 international societies, and then out of this project, now we have the recently released pediatric and adult brain death guidelines in one document instead of 2 that was just released in 2023. All right, why am I going through all of this painful history? It's because the changes to the new guidelines are meant to decrease practice variation in how death is pronounced, which is, we think, a pretty big deal. There are several changes to the new guideline, including what prerequisites need to be met before patients are tested for brain death, specific things to brain death testing, and also specific things to the apnea test. Now, the apnea test, right, is it's probably the one aspect of brain death that raises the most ethical questions. It's where you take a patient off of the ventilator, you allow for the carbon dioxide to rise in their blood, and you see whether they're going to take a breath. If they do not take a breath, it is evidence that the brainstem does not function. Now, many people have argued taking somebody off of the ventilator is actually dangerous. It is not within the scope of routine medical care. And so if it's dangerous, how can we do this without consent? And also, are we harming our patients by trying to declare them brain dead? What if they're not really brain dead, but because we did the apnea test, we now move them a little bit closer towards brain death? So as you can tell, there continue to be ongoing questions about brain death, even though we have these guidelines, right? One more new change to the guidelines, this ancillary testing, and instructions of how to perform an apnea challenge while on ECMO. So ECMO, especially eCPR, so patient comes in having active resuscitation with cardiopulmonary resuscitation. eCPR is when you transition them from CPR straight onto the ECMO machine. Now, if you're able to do this, typically within 30 minutes of rolling into the ED, you can cannulate the femoral artery and the femoral vein. That's fantastic if patients actually do well. But if they go on to suffer severe anoxic brain injury and they meet criteria for brain death, how do you pronounce brain death when they're on ECMO, which is essentially a heart-lung machine? So, ongoing questions. One big question is evidence of neuroendocrine function consistent with brain death? And this means that the brain controls the production and the levels of different hormones in your body. And if there's evidence of hormonal activity, is that consistent with brain death? Again, we go back to this definition, right, from the Uniform Determination of Death Act, which was the complete cessation of the entire brain. So a lot of discussion about whether neuroendocrine function is actually part of the entire brain. The US and the World Brain Death Project guidelines do state in their new guidelines that patients can have evidence of neuroendocrine function and still be pronounced brain dead. In the clinical setting, that means that if you are not in diabetes insipidus, you still have evidence of the hormone that's able to control water balance in your body, you can still be brain dead. Is consent required before performing brain testing for brain death? Now, remember, we talked about this apnea challenge where it had the potential to perhaps harm patients even further. In this document, it says that consent is not required, but reasonable attempts should be made to inform the family of the intention to perform brain death testing. Now, I would have to say this is pretty hotly contested. In the Google Drive, by the way, which you can access by scanning this QR code here, in the Google Drive, there will be references if you want to go down the rabbit hole of this. What if the family objects to brain death testing? This is happening more and more. So for those of you who do clinical ethics consults, you have no doubt run into this. Objections can be from a variety of things. Families can object because they don't even believe in the concept of brain death. Families can object because although they may believe in the concept of brain death, they don't believe it's true for their loved one, or they may have an objection to a certain component of brain death testing. And so this is the recommendation of the 2023 AAN guidelines. First, you get guidance and support from clinical ethics, yay for us, legal, and also hospital administration. We should try to resolve these issues before turning to the legal system. I would wholeheartedly agree with this. Continuation of organ support. So this is something that is very carefully written that I want to point out. After declaration of brain death, you're no longer technically alive, and so you are no longer on life support. You are on organ support. And it can be very confusing for families when we tell them in one breath, your loved one is no longer alive, but they're still on life support. So just important for terminology. So we call it organ support. It is appropriate to continue organ support following brain death declaration for a limited period of time, and they actually define it here as less than 48 hours. Families should be allowed to seek a second opinion or even given a finite amount of time to seek transfer to another hospital. And they should be informed that after declaration of brain death, CPR will not be performed in the event of cardiac cessation. This is new and I think really important to put in there because these don't pop up very often, but there are a couple of consults, right? Karen, you probably had, who come up, patient has been pronounced brain dead, but family is still coming to terms with, and then coming to terms with the diagnosis. The cardiac, nothing has changed, no code status has changed in the chart. There is cessation of cardiac activity, and then all of a sudden CPR is being performed on the patient. There are also ongoing legal questions because if we go back to this quote, which is irreversible cessation of all functions of the entire brain, and it says here, a determination of death must be made in accordance to accepted medical standards. What is unclear is the AAN guidelines, which I just went over, which is accepted medical standards. It is unclear whether these accepted medical standards actually meet the standard of irreversible cessation of all functions of the entire brain. Are we sure that every single brain cell is no longer functional? No. We just are sure that there are not enough neurons working in concert together, which generates a response that we can then detect. So if we are talking about a functional definition of brain function, this would seem actually to be a physiologic definition of brain function. So here we have two different definitions of brain function, right? It's either physiologic, which is irreversible cessation of all functions of the brain, or functional, and it's functional because we have no technology available to us to actually check whether every single cell in the brain is actually non-functional. To make matters worse, we have states that have different laws governing brain death. New Jersey allows for families to refuse brain death testing based on personal religious belief. And Nevada, because there was a case which actually challenged whether the termination of death in accordance to accepted medical standards actually met this standard here, Nevada changed their law to state that brain death needed to be declared according to these guidelines. Well, guess what? The guidelines just changed. So in Nevada, are you out of compliance with the law if you declare brain death according to 2023 guidelines? So in response to all of these questions, the Uniform Law Commission started meeting to see whether they needed to revise the Uniform Determination of Death Act. They decided to suspend their efforts. I think the conversation was a little bit contentious. Again, if you have questions, we'll take them after the presentation, but here are the references. Please go to the Google Drive. All right, providing care for transgender patients. This is a great website that I want to refer you to, translegislation.com, which is a legislation tracker of all of the bills all over the U.S. Where there is proposed legislation that affects patients who are transgender or have other non-conforming genders. 550 bills, 42 states. The legislation that's being proposed affects every aspect, it seems, of life, right? These are just a few of the things that are listed. So the legislation, it covers education, what can be covered in education, what can be taught as curriculum, what cannot be taught as curriculum, sports, participation, healthcare, what can be provided during the healthcare encounter, and also bathrooms. Care of both the pediatric and adult patients are affected by this legislation. If we are practicing in an area where there is active legislation on the type of care that we can provide on transgender patients, what should we do? It's really important to know that every major medical association has issued statements in support of healthcare for transgender patients. Every single major medical association, right? This is just two that are particularly pertinent for my practice. American Academy of Pediatrics published guidelines in 2018. They reaffirmed them in 2023. In 2023, JAMA published standards of care for transgender and gender diverse people. So why are there so many questions about gender affirming care and care for transgender patients? Quite frankly, we do not have a lot of good evidence to guide our decision making. So let's be honest about that. In 2024, the CAS report was just recently released in the UK. I don't know how many of you have had a chance to flip through it. It's very long. It's also in the Google Drive. But here's a quote from Dr. Hilary Cass. "There is not a reliable evidence base upon which to make clinical decisions for children and their families to make informed choices." This is true. There is not a good clinical evidence base. So if there is not a good clinical evidence base, I don't know about you, but I just don't think this is a good time to start making legislation. How do we react, again, when there is little medical evidence to guide decision making? I just want to say that this is not new, right? Having or treating medical diagnoses with little evidence base is actually medicine altogether, right? We have medical evidence because we started treating patients without having medical evidence base, or without having an evidence base for medicine. We develop the evidence base as we treat patients. We see how they do. We incorporate that evidence into then revising our guidelines. So we want to, first of all, commit to obtaining better medical evidence, and we only do this when we continue to care for patients who are transgender. We have to find out more, right, about our available medical evidence. We should expect more complexity before we have clarity. And again, this is true for every major thing that we've undertaken. So I want to, just as an example, I think back to when I started fellowship in Peds Critical Care Medicine, or actually, let's even go back further. This is now a long time ago. When I started residency. When I started residency and I was an intern, I did a combined internal medicine pediatric residency. And my intern year of internal medicine, I admitted a patient in septic shock. And you know what the rule was? The rule was that you keep bolusing them with fluids until you put them in pulmonary edema. And once you put them in pulmonary edema, you pat yourself on the back. Does this ring a bell? Yeah. You pat yourself on the back and you say, yes, I've just earned myself another procedure. You intubate them, you stick them on a ventilator. And now you have just, saved their life. Now we know that for every extra ml of fluid that you put into a patient, you have to account for that, because every single percent fluid overload your patient has actually increases their mortality and morbidity. That's a huge change, right? And we only got to the evidence that we know now because we started treating patients without a solid medical evidence base. Does that make sense? We cannot know how to treat patients better if we stop trying to treat them. We treat the issues and diagnoses that we already know how to treat. We know how to treat urinary tract infections. We treat that. We know how to refer for mental health care. We treat that. We do not want to limit healthcare that is part of the whole person care, spiritual care, attending to the distress that can occur when you are not living in congruence with some part of your body. And again, referral to specialists. So I want to I want to stress the ethical issues are not necessarily new issues. These are issues that we face with every single new diagnoses that we come into contact with. But yes, there are significant ethical issues that are associated. I would suggest that we split out ordinary care from gender-specific care, meaning that if you're not comfortable with hormone therapy or hormone replacement, that's okay. We can still continue to take care and to provide ordinary care. But the questions that still come up that we really need to have answers with are, what are the criteria for diagnosis, right? How effective should treatment be before it's required? Who should give consent on behalf of pediatric patients? Now, especially these last two questions, these are not new questions, right? How effective should treatment be before it is required? I'll give you a really quick example of congenital cardiac surgery. If you have hypoplastic left heart syndrome, and you were born in the 1990s and 1980s, your mortality rate was really high. It was on the order of almost certainly fatal. Then they developed cardiac transplant and this series of staged palliative surgeries, and now the mortality rate for hypoplastic left heart syndrome is somewhere around 25%. That's extraordinary. A 75% reduction in mortality, but is that enough to mandate that every single child with hypoplastic left heart syndrome undergo this surgery? It's not, actually. We still allow parents the option to decline aggressive therapy. I love this. There's a tool called Competence Consultant Ethics Support Tool. It comes out from the UK, but it's also in the Dropbox. But it's a series, or it's a process with a series of questions that helps to identify the doubts, the questions, where to seek guidance, and also to have final conclusions and reflections. So it's a deeply personal process that clinicians can undergo. The last thing I would say about transgender care is that we need to focus on supporting, and this is coming from sort of the healthcare administrative lens, we need to focus on supporting the patient-clinician relationship rather than trying to advocate for legal legislation. Supporting the patient-clinician relationship. Where are we going to find the moral clarity to know the next best thing to do for our patient? It's going to be within the physician-patient relationship or the clinician-patient relationship. All right, how am I doing on time? Better than I thought. Okay, last topic, which is a mouthful, normothermic regional perfusion with controlled donation of the cardiac death. Again, we're going to go back to, there's two ways to be declared dead, cardiopulmonary criteria or brain death. I put this up here just to say that right before 1968, with the publication of this article, 1967, the first human-to-human heart transplant in South Africa. So in organ donation, we have something called the dead donor rule, meaning that you cannot cause death by procuring vital organs. You can take organs from people who have already been declared dead. So in order to honor the dead donor rule, the primary source of donated organs have traditionally been from brain-dead patients, but we don't have enough organs. So then doctors said, well, what if we could procure organs who die by cardiopulmonary criteria? And so we developed then DCD, or donation after cardiac death, in which you take a patient in a perioperative environment, you withdraw life-sustaining treatment. Well, first of all, the patient makes a decision, or the surrogate makes a decision to withdraw life-sustaining treatment, which is something that is, again, we do fairly often. And then after the decision to withdraw life-sustaining treatment, then the family or the patient if the patient has already been an organ donor, then they're a candidate for organ donation or DCD, or the family is approached for consent for organ donation. If that all goes through, they're taken into the perioperative area, life-sustaining treatment is withdrawn, the patient is pronounced dead. There is a period of waiting to make sure that the heart does not spontaneously start beating again and circulation is restored. And then after that period of waiting, then the primary team exits and the organ transplant team enters, and then they procure organs. Now, this has helped to increase the number of organs, but only for certain organs, because the heart, for example, needs a steady supply of oxygen. And so if you are withdrawing life-sustaining treatment and their oxygen saturations are going down to 0, then the heart stops because of acute hypoxia. And then, damage is being done. Then you're waiting. For example, damage is being done to these organs. So the waiting period, the increased hypoxia, this limits the number of organs that can be recovered. So what if we could withdraw life-sustaining treatment, allow the patient to die, wait, and then instead of actually procuring the organs, stick them up and hook them up to ECMO, essentially a heart-lung machine, reperfuse their organs, get that heart beating again, and then let oxygen circulate in these organs to minimize any damage that was done during the withdrawal of treatment phase. And then we could increase the number and quality of viable organs. This is NRP DCD. This is sort of the list. I'm not going to go through that, but if you want to watch a video, go to this link and you can watch the video. So I want to say again, the patient's heart stops. They're declared dead by cardiopulmonary criteria. You wait for a period, and then you cannulate the heart again. You restart, or you pump it with fluid, donor blood. You restart the beating heart. Lots of questions that come up from this. So if you restore perfusion, especially circulatory function, were they really dead? One thing I didn't go through is that prior to starting them on ECMO or cardio bypass, the cerebral vessels are clamped, meaning that the blood vessels carrying blood to the brain are clamped off. Well, if they're dead, why would you need to clamp them off? The concern is that if they're perhaps, the brain is not all the way dead, and you restart the heart and you restart circulation into the brain, then you would have the patient start to live again. So we don't want that because they've already been declared dead, so we're going to clamp the cerebral vessels. So if you're thinking, I am really confused, I would agree, because if they died from cardiopulmonary criteria, you know that not all the brain cells are dead, but we don't want them to wake up again and say, hey, what are you doing to me? We're going to clamp off the blood vessels. Is that active, like an active act of making a patient stay dead? I guess another way around it is even if you perfused the brain, there would be such bad damage done to the brain at that point anyway that it would not be a quality of life that the patient would want to live in. But then that's really getting to a functional definition of life, right? Questions? All right, what kind of informed consent should the family sign? I'm just saying from my perspective, I have a number of years in the medical field. I feel like I have quite a bit of experience, and it took me a little while to get through this and understand it. I just putting myself in the position of a family member who is grieving the loss of their loved one, and then how much of this are they absorbing? Is informed consent truly obtained prior to this procedure? And then what kinds of patients could this protocol be preferentially applied to, right? So would we do this for certain patients but not others? Again, lots of questions that come up. articles in the Google Drive are available. I'm not trying to sound pejorative. I'm not. I understand the life-saving treatments of organ transplantation. It feels, though, that, again, if we go back to the medical question, can we? Yes, we can. Should we? I'm not sure that we have answered that to a satisfactory level where we should actually continue on with the can we. That's it. Now, Gina, I'm going to invite you to come back up. We are happy to take questions about the topics that we've talked about, or really any other questions that may strike your fancy. Don't open it at that broad. All right, Gina says don't open it. Just kidding. Oh, do you want to...
Go right ahead. Oh, should I'll run back here and make sure your question is well heard.
Thank you. I appreciate that. One of the questions for the last segment that you did on organ procurement, one of the criteria was that the individual has chosen not to live with whatever the quality of life. So death with dignity, I know, is a lot of, we're doing that now. But is there any guidelines? Can you just remind us or tell us what sorts of things fall into when do I decide that I would like to die with dignity and not experience whatever it is? Being in Michigan, Dr. Kevorkian was one of our, the first persons that I feel like started that conversation. So where are we now with what is allowed to be an assisted death?
Ooh, I'll take that one. That's kind of up my alley. So there's about 10 states plus DC, I think, that have that have laws that say that if you have a terminal condition, typically less than 6 months to live, you have decision-making capacity, you don't have any mental health disorder that affects your decision, that you can obtain a prescription that you must ingest on your own to end your life. And that's very different, actually, than withdrawing life-sustaining treatment because you find it burdensome and not helping you to meet your goals or values. Really interesting. I went to this fascinating conference in Utah in March. It's called ISIL, International Conference on End-of-Life Care, Law, Ethics, Practice, and Policy. And I thought, well, that will be really interesting. It was interesting. It just wasn't what I thought it would be. It was all about how do we increase physician aid in dying across the world. And they kind of poo-pooed palliative care. Palliative care. You guys say you're here to relieve suffering, but you can't relieve all suffering. So clearly we need physician aid in dying. So I was like a fish out of water there. But it was very, very interesting. So more and more laws are being brought up in legislations across the country. And it'll be interesting to see where this goes. Australia now is doing it with lots of, a lot of regulations. Canada, it's interesting because the Canadians think that we're kind of barbaric in that we make people swallow medication when they're sick and not feeling well. In Canada, like 95+% are done with physician injections, so that there's no question about whether you're going to get the full amount of medication. So it's very interesting to see where this is going. But if you want a really great film to watch that talks about this, called The Last Flight Home, it's actually really good. I always like the stories about these cases because I think the stories are more illustrative than maybe a lecture. But Last Flight Home, I think it's on Netflix. All right, and let me see. He's gonna. This one's gonna be for you. Okay.
First, I want to say thank you for bringing these issues up. We do not have 5 minutes to conquer this and figure it out. But what's interesting to me through all of this is discerning preemptive actions versus natural processes. And there's quite a number of highlights that are sort of playing with a preemptive act versus allowing a natural process to happen. With our ventilators, with the clamping of the arteries, there's things happening here that are preemptive actions of another person. and not the patient's natural process of dying. There are interferences, and so the ethical question is, what interferences are permissible and which ones are going to cross the line? So if you're clamping off arteries to ensure the death of someone, just that concept right there. Why? Okay, and what if the clamping is the one that kills the patient and not the other things? I'm not here to try to, I'm just wanting us to think clearly about actions, artificial actions, or preemptive actions versus natural processes of someone dying. So is it okay to do these extra actions and preemptive actions to ensure that we can save the organs? Is that okay to do that?
Yeah. Is it okay? So I'm going to answer this by saying, if you've already been declared dead, why does it matter? Does what you do after a patient has been declared dead have moral significance? I would argue it does, because we know that the continuum between life and death is not so clear sometimes. Sometimes it's hard to tell when you're prolonging death versus prolonging life. And I think the same thing applies for when we're doing, when we artificially try to delineate a time where death occurs, and by then, all of our actions have no moral significance. I personally don't think that is a morally persuasive position. So if we follow that logic and thinking that if after you declare death, then let's just say, then all actions after the declaration of death do not have moral significance, there is no need to clamp. Why would you clamp? They're dead. If you then argue, well, I know there's no moral significance, but it'll make us feel better. Well, what is the basis of that? So the preemptive action, whether it is justifiable or not, right, should cause us to examine the basis of why we're making these decisions to begin with. Now, I'll know just personally, like one of my biases is that when I truly understood what brain death was, I had an existential crisis. I'm not joking about this. And, I'm peds critical care. This is what I do. I declare brain death in children. And I had an existential crisis because part of my belief is that it's very difficult to clearly delineate out between life and death. You have to accept some functional capacity that is associated with life. You have to. You cannot ensure that every single brain cell is dead when you declare brain death. And the reason why I think this is really important for us to discuss and to ponder in a couple of different areas is because if you can't define death, how do you define life? And if you can't clearly define either of those two areas, it probably is not a good idea to legislate black and white barriers around decisions whose moral clarity can only be found in a relationship. And that is a relationship between the clinician and the patient.
One clarification is that assumes that laws are created only when there's clarity. Aren't laws sometimes created when there's ambiguity? They're protective laws for ambiguity spaces. So, you could be activist for legislation for safe spaces when there's ambiguity. Sometimes it works both ways with legislators. It's just harder to have a conversation with legislators when there's ambiguity. So that's why I was kind of...
No, that's true.
Sometimes you want protections when there is gray areas.
So I just want to say, there's like this sweet spot, right? There's contexts where there is little ambiguity. Those contexts are ripe for legislation. And then there's contexts where there is so much ambiguity that the legislation actually creates more confusion than clarity. Yeah.
Yes, thank you. Very interesting. I had a question. I think you just touched a little bit when you talked about patient and physician relationship. That was my question. It pretty much stemmed from the very first presentation. And it's been kind of remain in my head a little bit when I've heard all the legislation that's been going around about abortion. Is this, how does this impact the trust that the patients have on on their physicians? Because as a patient, I'm thinking I'm going to my physician, and I expect them to act on my behalf with their knowledge and expertise. Yet if they are somewhat inhibited, and they have to constantly balance their personal welfare when they make a medical decision. Can you speak a little bit on what that's done lately to the trust, perhaps, in healthcare?
I think that's one of the most concerning questions, because I would say in all of these issues, really probably the most important thing in most of medicine, right, is the physician-patient relationship. It's the rapport, it's the relationship that you have, that particularly in palliative care, right? I don't have real cool, awesome drugs and immunotherapy and surgeries to give people. What do I have? I have myself. I have my presence, right? Presence is a big part of it. Our team's presence, that's everything. And so there is this concern. The really interesting thing about these abortion laws is that you're really asking doctors, please don't practice the standard of care. The standard of care typically says, if your life might be in danger, your health might be in danger, I better act. Now, if I don't act, you might be fine. But we generally in medicine don't say, we're going to wait, right? We don't say to the middle-aged banker who comes in with chest pain, I don't know if this is a heart attack, but you know what? Why don't you just go, wait in your car for a while. If you're still having chest pain or shortness of breath, come back. We don't do that. We are on the ball, right? We're getting EKGs and troponins and all of these things to make sure that we rule out these bad things and intervene before there's this descent into potential death. And in these abortion laws, the problem is that we're saying, I don't know if you're going to get sick from this or not, but you're not sick enough for me to act because I might end up in jail, so we're going to wait. We're going to wait, and let's just see what happens. And that is so antithetical to how we practice medicine. And so I think it's going to have incredible consequences. And you're absolutely right. I think it does. It violates the standard of care, and I think often it violates the patient-physician relationship. Yeah.
I just want to add one more thing quickly, and I know we're over time, but this gets back to what, Dwayne, what you were saying. Does the law add clarity? I personally think that the optimal role of the law is to optimize our society so that we are actually able to take care of each other. So we say, you can't do these things because if you do these things, it's going to fracture your ability to take care or to interact humanly and relationally with somebody to the point where it's not possible. So you can't do these things, right? You can't kill somebody else because you can't relationally interact with somebody who's dead. So we're going to say that is outlawed. So if we think of laws as tools that we have at our disposal to optimally promote better relationships and better medical health care, I think that's the standard by which we actually evaluate whether our laws are effective or good or not. All right. I think we're at time.
Thank you all.
Okay.
Thank you so much.
So this brings us to the end of day one. Thank you, everybody, and I hope this day has been enlightening for you. Just a couple of quick announcements. We do have parking shuttles who will take you back to your car if you're in the parking lot. Here's some things to look forward for tomorrow. We had a call for papers and abstracts, and those presenters will be presenting tomorrow. It's going to be during lunch, so I want to encourage you to grab a quick lunch, come back and listen to our presenters. We have 4 fabulous presentations. The abstracts and the schedule for the presentation is in the Google Drive. If you're wondering where can I get access to these PowerPoints, to the materials that have been referenced, please scan the QR code. That should take you to the Google Drive. If you can't access it, please let me know, and then we'll make sure that we can fix that. And last but not least, if you've not gotten a copy of Alex Bryan's book, Medicine is Prophecy, please don't leave without one. We have plenty of copies. Magella has copies here in the back. And any other? Okay. All right. Thanks, guys. We'll see you back tomorrow.